like to present the case of relatively rare bony lesion resulted in wrist deformity. So it's a 9-year-old boy, sustained metadiaphyseal radius ulnar fracture, which healed actually and eventually in 1 month. But in 5 years, he came back to outpatient clinic with some kind of wrist deformity, pain on forearm load, and limited pronation and radial deviation. He was referred to CT scan, and it was discussed with family as a treatment option, and he disappeared until 2018 and came with worsening of the deformity, pain, and limited pronation up to 20 degrees. So he was scheduled to surgery, and it's pre-op images. So what is the reason for his deformity? It's pre-op clinical pictures, his forearm and wrist. So focal fibrocartilaginous dysplasia, it's uncommon benign bony lesion which deforms the long bones in children. First described by Bell and in 1985, and so far around 60 cases have been reported. It's predominantly occurs in tibia, in proximal tibia, but also reported in femur, humerus, forearm, phalanx, vertebrae, and ribs. It's a variant of fibrous dysplasia, but in contrast to fibrous dysplasia, there are histologically cartilaginous elements and not purely fibrous ones. Etiology is unknown, and diagnostic criteria are clinical signs, unilateral angular deformity in a long bone in a young child, and radiological signs, typical well-defined loosened bony defect in the metaphyseal cortex with surrounding sclerosis. Lower limbs lesions usually presented in younger patients, and upper limb lesions usually in older individuals. In the upper extremity, 23 cases have been reported so far. 15 of them involve the ulna. In terms of natural history, it mostly related to the tibial deformity. Spontaneous correction should be expected if the varus is less than 30 degrees, and more severe deformity needs some kind of surgical treatment. Here are the clinical pictures of small cases. Dr. N.Simanovsky provided it. We can see the varus deformity of proximal tibia, and with growth it's actually remodeled. Treatment options: observation, debridement of fibrous scissor at young age, and we can expect that deformity will remodel. Another option is guided growth or osteotomy. We decided to proceed with osteotomy, with closing wedge, shortening radial osteotomy, and we had to ostomize the ulna because it was pretty difficult to reduce the radial osteotomy. We fixed it with Kirschner wire and put the plate to the distal ulna. In 1 month, we take the wires off and put additional 2 weeks splint. And when we take the cast, the deformity was corrected, and osteotomy was healed well. And what is interesting, the lesion, it's 2 months after the surgery, is going to disappear. So the patient regained his range of motion, the pain was eliminated, and biomechanics of wrist motion was restored. So he regained the normal function.